Turn your camera on at the bottom too.
Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Ali Asghari. I'm Professor of Disaster and Emergency Management and also Director of CFAL York at York University. I would like to officially open the first session of our 2026 Emergency Management in Hospital and Healthcare Speaker Series, presented to you in partnership with the Thunder Bay Regional Health Science Center. Also would like to begin today with a short land acknowledgement. We at York University acknowledge that many indigenous nations have long-standing relationship with the territory on which our campuses are located. Relationships that precede the establishment of York University. These areas have been cared for by and are now home to many First Nations, Inuit, and Métis communities. As this is also an online event, I strongly encourage you to learn about your traditional land upon which you are located. With this, I welcome our moderator, our panelists, and our participants from around the world. Welcome to our webinar. This has been a very professional, informative speaker series, and that is the best reasons we have continued this by entering in the third year now. It's now my great pleasure to introduce to you our moderator for today and all future sessions, Misha Richard. Misha is the current emergency preparedness lead for the Thunder Bay Regional Health Science Center in Thunder Bay, Ontario, Canada. In this role, she serves as a subject matter expert, assisting with the development and maintenance of emergency management governance, training materials, and exercises. She holds a Master of Disaster and Emergency Management degree from York University and bachelor degrees from Western University and Brandon University in the focus areas of political science and disaster studies. And I share two universities with Misha, both at York and Brandon University. Misha, thank you very much for moderating today's session, and also very much appreciate your ongoing help and support in putting this very, very interesting and important speaker series together. The floor is yours.
Well, hello everybody, and thank you for that warm welcome, Ali. I appreciate it. But the series wouldn't be anything without our speakers, and I'm very grateful that we have four speakers with us today to talk about a very important topic. But before I get into that, just a quick reminder for housekeeping. I know we probably have a couple of new attendees, so the chat is open and active. I can already see people providing their introductions to one another from wherever they are in the world right now. So feel free to have that peer dialogue ongoing throughout the session today. But if you have questions that you would like directed specifically towards any one of our panelists or to the panel as a whole, we do have the Q&A function, and I encourage you to put those questions directly in there. I will do my best to address them. We're going to start off with more of a formal presentation from one of our speakers, a little bit of a touch base to the rest of our panelists, and then we'll be able to turn things over to general questions. So I'll get started and introduce our first speaker. So Danielle Fuchko is a registered nurse who's worked at the Calgary Firefighters Burn Treatment Center and also serves as the Canadian Region Burn Disaster Coordinator for the American Burn Association. So thank you so much. This panel would not have been possible without her coordination, so extra kudos to her for wrangling some of her peers together to speak. Then I'll also introduce Mo Arbab Hasari. Mo is a registered nurse and is the operations manager for the Burns Trauma and High Acuity Unit at Vancouver General Hospital. He also sits as a member of the Emergency Management Committee for Vancouver Acuity within Health Emergency Management BC, or HEMBC, if you've heard that acronym floated around before. I also want to welcome Dr. Claudia Malik to the panel. She's been caring for pediatric plastic surgery and burn patients since 2014 in Ottawa at CHEO. She's also an associate professor at the University of Ottawa. Just to clarify, I'm going to put everybody's full bios in the chat momentarily because there's a lot more interesting details about each of these speakers. And last but definitely not least, we also have Stephanie Chadwick with us today, providing an interesting perspective as she's a nurse practitioner, burn certified and wound ostomy continence certified nurse. And she also has been specializing in outpatient burn, CO2, laser injection clinics, so on. And so again, I'm going to throw all these extra details about our speakers into the chat. But right before I mute myself, I will say thank you again to everybody for taking part in the session. If you have questions, throw them in that Q&A. Now it's over to you, Danielle. Lead us off in the presentation. Thank you.
Thank you so much for that introduction, and thank you for having us, and thank you to my panelists for letting me peer pressure all of them for joining me. I really appreciate the different perspectives and the support. So just to start us off today, I'm just going to give a little bit of a background about burn care in general and how burns are special when it comes to mass casualty incident response planning. I always like to open with this photo. This is a picture from Fort McMurray, Alberta in May of 2016, where we had a devastating wildland urban interface fire. And thankfully, no burn injuries from this incident, but they did have to evacuate over 80,000 people within a 24-hour notice on a single lane highway with only one exit. So lots of learnings had there, and maybe many folks on the call have firsthand experience with that emergency response. So it's certainly something that's always on the top of our mind, especially in the West with wildfire. So just to give a little bit of an overview for those folks who aren't as familiar with burn care is a very unique specialization. Burn patients are very special, and we all love and are very passionate about burns. But there's a few things about burn patients that we need to keep in mind when we're thinking about burn patients within the context of a mass casualty incident. So first and foremost, a burn patient on scene, even if they have extensive injuries, can often be alert, they're walking, they're talking, and they are at high risk for decompensation within about the first 48 hours. We can have loss of airway. We have unique fluid resuscitation needs required with very skilled titration to prevent burn shock. And we can have quite a formation of massive edema that might need an urgent surgical intervention. So the critical needs within those first few hours are very high, and the patient does change quite rapidly in those hours. Burn patients also have a pretty long length of stay in hospital when compared with other types of general trauma patients. So if you're thinking of car accidents or a mass shooting, burn patients are typically in hospital for weeks, sometimes months, depending on how many types of surgeries they need and any kinds of outpatient services that are available in the area. So oftentimes when we have a burn patient come in, that is a prolonged hospitalization. Burn patients also need more resources than other generalized trauma patients. Most burn patients will require at least one surgery, if not sometimes multiple surgeries, and very unique wound care expertise. And we like to use very expensive dressings and requires very specialized skilled staffing to be utilizing these wound care supplies. Burn patients also have very unique rehabilitation needs. So our physiotherapists and our occupational therapists are key members of our burn care team. And these rehabilitation needs start from the moment the patient is admitted to hospital and can continue for months to years post-injury. So the effects of having multiple burn patients present at once transition from our inpatient units to our outpatient burn care facilities as well. Really, they need that support to help maintain their mobility, range of motion, and ongoing scar management. And of course, as you can imagine, psychological supports are a big component of burn care. Here in Calgary, we're very fortunate to have a very robust peer support program, and it's very targeted to the unique challenges associated with burn injury. So long and short of it is we love our burn patients. We want to care for our burn patients at the burn center to try to ensure they have the best care that they possibly can. Gets tricky. Okay, so where is our burn care in Canada? So starting from the west, in Victoria, they have a small burn program. They have about 4 burn beds, and they have a limitation for how big of a total body surface area burn they can take. So somewhere around like 20 to 30%. Anything above that, they'd be looking to transfer to Mo's team in Vancouver. Vancouver, of course, has a robust full burn care program. In Alberta, we are fortunate we have 2 burn centers, myself here in Calgary, our team, as well as the team in Edmonton. Kind of spotty services available across Saskatchewan, so I didn't include them, but there is a burn program in Winnipeg. Then we're going over to Toronto with the Ross Tilley Burn Center in Toronto, and Hamilton, where Stephanie is from. Ottawa gets a gold star because they are pediatrics only, which is where Dr. Malik is from. Quebec has Quebec City and Montreal, and then the Maritimes are all looking at Halifax, Nova Scotia. So as you can see, pretty sparse across the country in general. Does anyone want to throw a guess in the chat of how many burn beds or how many burn patients these burn centers collectively can care for at one time? What's our burn bed capacity in Canada? I'm seeing a guess of 210. Misha, do you want to guess?
I know I'm seeing 70. I was gonna say maybe 40.
Yeah, sick kids, yeah, for sure. I'm sure I should have clarified. I'm talking about adult, but Dr. Malik is going to address the pediatric component here at the end. So we're getting actually a pretty good range of guesses here. Yeah, so we're looking at about 102 adult burn beds with maybe 35 to 40 pediatric burn beds. And one of the reasons I say maybe and about is this is a guesstimate. In Canada, we don't often have standalone burn units that just have beds waiting for burn patients. Most of our burn care programs across Canada are integrated into general systems, ICUs, or other inpatient surgical units like plastic surgery. So most of the time, we don't have a dedicated burn bed, so it's hard to say how many burn beds we have across the country. I don't know how everybody else is doing for healthcare these days, but here in Alberta, we are struggling with capacity. Oftentimes, our hospitals are 100 to 110% capacity. So when we don't have burn patients in our burn beds, they're filled with something else. So these are not 100 burn beds that are just sitting empty, waiting for someone to have a burn injury. These are often beds that we are challenging our systems to try to move patients around to get them the best care. So a tentative 100 burn beds across the country for adults. The American Burn Association recommends a surge capacity of 1.5 times baseline, so another 50-ish beds. But again, that can be challenging depending on other site capacities. So what is a burn mass casualty or BMCI? Really simply put, it's just where we have too many burn patients and not enough resources. So we don't affix a certain set number of patients to this. It's a very generalized supply and demand mismatch. Now, this photo is a picture taken on scene from a house explosion we had in Calgary here in March of 2023. Unfortunately, it was an incident of a improperly installed hot water tank, which led to a gas leak. There were 13 people living in this house, 10 of which were at home at the time of the incident. And as you can see, there's no structure left. Thankfully, all 10 people made it out alive, 7 with pretty significant burn injuries. So we had 7 burn patients admitted to our burn center simultaneously, which is the highest number of simultaneously presenting patients to our burn center ever in the 45-year history of our burn center. 7 patients doesn't sound like a lot, but it taxed us for months, and we have had lots of great learnings and are currently working on reviewing all of these learnings and hopefully getting something together for publication. I love to talk about burn mass casualties, and one of the questions I often get, or kind of the pushback, is, well, it's not really something that we have to worry about here in Canada. I'm sure by now pretty much everybody on this call would have heard of the devastating nightclub fire that happened in Switzerland on New Year's Eve just this past year. When I read about this incident, I just thought immediately of Banff, Alberta. If any of you have ever been to Banff, it's very similar, very busy, packed in tourists, lots of young people, lots of parties. Or if you've ever been to the Calgary Stampede, the bars are full, the tents are full. We have high congregation of people. So beside that, we've got lots of recent examples. So this is a workplace incident that occurred in Toronto just a few months ago and ended up having 6 burn patients present simultaneously to the Ross Tilley Burn Center. And this was a burn mass casualty incident for them, and they've done a great review of the impact of this. Homelessness is a huge challenge across the country, and certainly something that we're seeing more and more of. Encampment fires are a huge risk, and we are seeing more individual patients presenting with burns resulting from unsafe heating or cooking practices. But it's a pretty high risk for a whole encampment to go up in flames. Everything there is very flammable. There's lots of open fuel. Everything's made of tent material, that polyurethane, so very high risk. Wildfire has always been a huge risk in Canada, but now we're seeing wildfire in areas that we wouldn't traditionally associate with high wildland urban interface fire risk. And many of you folks might recall the Lac-Mégantic train derailment disaster, where a train carrying fuel derailed and exploded and killed 47 people. There was only 1 burn injury from this because the heat of the explosion was so intense. Anyone within the radius, unfortunately, did not survive. And we ship a lot of volatile material all across this country, so definitely we have this risk profile. So what do other places around the world do? First and foremost, the World Health Organization supports burn-specific disaster planning wholeheartedly, and they have recently published the standards and recommendations for what should we do? What should we have in place for a burn disaster plan? It's very extensive. If you want a really long read, the QR code is there. The UK has developed a national burn disaster plan post-Brexit. This was revamped or relooked at after Brexit. So I think we had somebody on here maybe from the UK. So that is now published. The European Union has a burn disaster plan, which they were able to put to the test during the Switzerland fire, and I'm hoping that they'll be publishing further findings on how that worked for them and if they have any changes they're going to make. Nordic countries have a burn-specific plan. And in the States, each burn center is supported to do burn disaster planning by a system of grants. So there's lots of state and federal funding opportunities for these burn centers to do this work, and is often a component of accreditation. The American Burn Association has a burn-specific accreditation, which they call verification, which requires burn disaster planning. As part of the ABA burn disaster efforts, they've divided the country into 5 geographic regions, and they consider Canada as the 6th geographic region. So that's where I come in as the Canadian coordinator. We are known as the Canadian Region Burn Disaster Consortium, and I am the liaison between our members and the American Burn Association Board of Directors. We are a fairly small but quite mighty group across Canada, and thank you to my panelists here who are part of this group. So we have 24 members from all 15 burn centers across Canada. We're really still kind of getting our traction, and our main goal and our function right now is just advocacy for this burn disaster preparedness. This is left to each individual burn center to come up with a burn disaster plan and to exercise it and to keep it up to date and have all of these programs in place. But as you can imagine, busy clinicians have lots of other competing priorities, and this is sometimes something that falls to the wayside or hasn't really even been considered or started yet. One thing I will mention, but I will leave until the very end if there is time. We do report our burn bed count, as it were, to this tool, which is hosted by the Nevada Hospital Association. So every burn center in the US and most of our Canadian ones are onboarded now and report how many burn patients we could take immediately and within 12 hours based on set triage criteria to this watchboard. And at the end, I'll share an email address if you're interested in getting access just to view the watchboard. It's open to anybody who has a reason to be looking at it. So anyone in emergency management or healthcare is welcome to have access. So reason we're here today is we have an ask for anyone who's working in emergency management, especially in healthcare emergency management. Your Canadian burn care teams need some help. We need some support to be doing this work to prepare for burn disasters. I really encourage everyone to reach out to their local burn team. If you aren't sure who that is or how to get into contact with them, you can get my information from Misha, and I'm happy to make some connections there. And we really need to emphasize that burn-specific plans are important to accommodate for those specialized equipment, the specialized staffing, the limited resources we have. I know in Canada we really rely and we love our all hazards plans, but we do need to have some specialized considerations. And just a reminder that a burn mass casualty has a really prolonged strain on our system. So we need to have that two-stage planning of this is how we're going to respond immediately, but this is our prolonged approach for staffing, for supplies, for all of those other resources that we require for those weeks, months phase here. And I like to put this picture in as proof that we can play nice between Calgary and Edmonton. At a conference last year, one of the people in this picture shared it, but they had photoshopped Oilers jerseys on us Calgary folks, and that was gloves off. So we do play nice most of the time. So I will happily turn it over to Dr. Malik.
Perfect, thank you. Good morning, good afternoon, good evening, everyone, whatever places you are signing in. Next slide. Okay, so Danielle talked a lot about the adults, and I think you think that is a problem. Let's look on to the children that unfortunately might sustain burn injuries as part of the MCI. Next slide, please. So I will use the same map that Danielle has used, and you will see in purple they are the areas where they can treat pediatric burn patients. So if we're taking from the west to the east, we have a place at BC Children's Hospital. Then if we're moving to Alberta, we have Edmonton and Calgary. And why they have a bigger star is because they are accredited by American Burn Association. As Danielle has mentioned before, they have an accreditation process, and you are recognized as a burn center by the American Burn Association. Moving along for Manitoba, there is no specialized hospital, but within their burn program, they are treating pediatric patients. When we move towards the Ontario, as Yvonne was mentioning in the chat, the sick kids is, I think, 3 times or 4 times already recognized as a pediatric burn center by the American Burn Association, and I think is the largest pediatric burn center that we have in Canada. In Ottawa, part of CHIO, where I work, we have a burn program, and in Montreal there is also a strong burn program within the pediatric hospital, as well as in IWK in Halifax. So if the adults there were sparse, we are even sparser from that, and that can create quite a lot of issues when you have a burn mass casualty incident. Next slide, please. So when we're looking for the pediatric burn capacity in Canada, I think what I will add to the brief summary that Danielle has mentioned is that it takes a village, we call it, to heal a burn and to make the burn patient be back home. So when we say take a village, it's multidisciplinary. You will have the OT, the PT, you will have the nurses, you will have speech and language pathologists, you will have social workers, you will have the psychologist, you will have the burn surgeon, the anesthetist, and the list can add on, depends on what other issues that patient may have because of either complications during the hospital or because onto a rehab something was affected, like speech and language therapy. Sometimes some of them they may need. So when we're looking for pediatric burn capacity in Canada, we have quite low number of pediatric burns, but with very high specialized needs. And if you looked onto the map, there is a geographic concentration of the expertise, and that makes us a bit more prone for issues and increase the system fragility. When we are looking for disaster scenarios, children, as you are aware, they are a highly vulnerable population for any trauma, but especially for burns, especially if they are extensive. And a disaster somewhere in any of the province can rapidly overwhelm the existing pediatric resources in terms of trauma overall, but also for burn injuries. Here in Ontario, we have the Ontario Emergency Management, and burns comes under their umbrella of all hazards emergency management, but also it's part of the accreditation Canada standards that each hospitals needs to have, is that what you'll do on mass casualty, and in some areas, especially in academic hospitals, is what you're doing for burns, where we have a burn program. Next slide. If we look onto the surgeon, how we coordinate and how we continue the care, again, we have a limited surge capacity for patients under 18 that they will require access, specialized access to operating room, to pediatric intensive cares, or to have really specialized staffing. And we are depending on the coordination between the provinces or between the facilities, and this needs to be timely. So simulations and scenarios of simulations needs to be built into that. Transport delays also can be a risk, and looking at the winter conditions, especially across Canada, that can be a major impasse, and that means that patients are held in hospitals where they do not have the capacity for them, they do not have the knowledge for them, and that can affect their outcomes, especially for big burns. So somebody in the community, or as I had some burns from up in Cochrane, they do not have the knowledge, neither the skills, neither I will deplete all their storage if I just want to put adaptic on all those burn wounds. So I think transport delays, it can create those issues. And when you're looking across the provinces or within the provinces or institutions, the readiness is variable. You may have somebody in Saskatchewan that may not even consider that what will happen in mass casualty. And when you're looking for sick kids, they have a robust burn casualty mass incidents. And again, you need to have a predefined response and protocols that we need to put in place across Canada and also in each of the provinces with regards when you escalate, when you transfer, and how we can be aligned from that perspective. Next one. So how we can mitigate it, or what potential solutions there are if we'll have a unified Canadian CI, is that we need to determine an early stabilization and damage control care to reduce the downstream risk. So it's at the scene when it happened. We need to use the concept of network models where maybe smaller centers stabilize and larger centers absorb the surge, which is not currently at the moment, but we need to consider and to sit down around the table and to see what is the best approach for that. To share protocols and real-time consultation in order to improve consistencies, especially if we need to transfer patients within the burn centers or within the same province, to integrate into the institutional disaster plans and HIRA processes. And also, it's not only what we're doing in action, but also what is the after-action review, what we can learn from some burn mass casualty incidents if those occur, not only, let's say, at the hospital level, but also to disseminate, as Danielle was saying, that what happened in Alberta, can we learn from those experiences and we can adjust from that. Thank you.
Great. So I think, Stephanie, it's over to you if you wanted to provide us with a quick snapshot of what the experience is like where you're at.
Okay. Hello. I'm hoping that I'm in there right now. Okay. Am I able to be seen now? I'm good. All right, perfect. Thank you. So Hamilton General Hospital is one of two regional burn centers, along with for adult patients. And we actually have established centers. We're preparing for verification, whereas Sunnybrook, our other co-managed burn center, is verified right now through the ABA. With our two adult sites, we have ability to actually be able to bring in patients into a designated center where we do have capacity for patients. However, very small, limited in that ability. We have, at our site itself, we have the ability to be able to have 4 ICU beds with an additional 4 ward beds. However, our site alone is also the regional trauma center and has capacity of 65 critical beds. So we liaison with critical, we liaison with our trauma team and the emergency department. And through the directors, the managers at the site, we are able to provide that surge capacity, acknowledging what is our limitation for staffing and resources as well. So there is also Sick Children's, which is a pediatric-based hospital out of Toronto, and the McMaster in Hamilton also has a children base for burn children. When we look at our capacity here, we provide ourselves where we do education and ongoing exercises to facilitate increasing our knowledge and ability and training to be able to look at mass casualty incidences, where we do this quarterly. We're still in the process of changing our policies and updating and revising our policies to be able to meet the standards across and globalize what we're doing for our care. Where I look at limitations, it would be resources still, because we are a very specialized area where we really need to have that focus from a dietitian and the social workers, occupational therapists, physiotherapists. But we also have to look at the nursing availability and supplies. So this is a big area that you need to be still looking at when it comes to mass casualty, and how are we succeeding to be able to look at it. that if you think across Canada, it's variable, all the formularies and dressing supplies, where we utilize very specialized advanced dressings, as you had focused on, Danielle, which is the same for our site. So we're in the development and looking at what could we be doing for assistance when it comes to supplies. As well, one area that I find when it's the specialization for burn survivors, as you said, they're not only from the immediate event that has transpired. We follow these patients for years, and they are burn survivors. However, they've been put through a significant trauma. And one area that could really look at is psychology and the need to improve on the access and ability for patients to be able to have the acceptance to be able to have psychology supports, counseling supports in a timely manner, whereas waiting lists are quite profound in our area throughout Canada. Overall, though, we are continuing to make sure that we can improve and maintain for our surge capacity. We can redirect patients from the emergency department. We can also look at surge capacity to another building to be able to see patients that may not warrant inpatient needs, but that could be transferred to outpatient. Our directors communicate with both sites to ensure when there is a critical call or a mass casualty that we can support each team for redirection as well during that period of time. Thank you.
Good morning, good afternoon, everyone. From Vancouver General, we've just started our burn mass casualty planning, and it comes in 3 phases for us. One is the burn unit, the other is emerge, and the third is working with trauma services. As Danielle mentioned, most of the mass casualty events usually involve all 3 services. So for us, it's working as a team and knowing our partners. So we've started to come up with a list and work together as to how best to manage patients who come in a mass casualty event. And now we're planning to do SIMs within our emerge department as to what would happen when you have 3 or 4 burns. How does trauma get involved? How does the burn surgeon get involved? And what does ED or emergency services, what do they do? We did have an event a few months ago within the Lower Mainland where there was a house explosion out in the valley in Langley, which is one of the suburbs here in Vancouver. And we had 4 patients arrive almost simultaneously in our emerge department. And while that might not be a lot, but we are very taxed where there's patients already in emerge. We're already surged in our wards, so it took a lot of resources from our emerge department, and from that, we've now built a new mass casualty incident specifically for burns that's in the early phases. But what I also want to emphasize that we're trying to do is also the psychological safety of the staff. When you have a mass event, it is very emotionally taxing, and ensuring that our staff are also able to take that in, have checkout times for them, check in on them, and have counselors available not only for the patients and the families, but also for the healthcare providers is really important and something we're trying to embed in our MCI. That's something that we learned with the Lapu Lapu event here in Vancouver that unfortunately happened a year ago. So for us, also bringing that aspect into the forefront is important because without our staff, you quickly run out of resources from that point of view. And we're also working within the province. As Dr. Malik had mentioned, it takes a village and the patients might not be able to come to VGH right away. So we've developed an education program for other bigger centers throughout the province to kind of educate them on what do you do with fluid resuscitation, dressing changes, how does that all look like, and having key partners in other regions of our province to ensure that if a patient can't get to us, the care that they need is done in a timely fashion elsewhere until the resources are available to transfer them to us, is another part that we're looking at. So those are some of the things that we've started. We are also going through the ABA verification. So there's lots of learning that's going through that process. So I'm sure we'll be tweaking things more. Thank you.
Okay, I think we'll pause there for questions, and then depending how much we get, I can talk a little bit more about the watchboard here that's on the screen. This is just a little screenshot, and you can see our triage colors of green, yellow, red with some considerations for burn. TBSA stands for total body surface area. Yeah, so I guess we'll open it up to the Q&A.
Honestly, Danielle, I was going to say, if you want to talk about this dashboard, have at her. And then I can start peppering you with some of the questions I have and some of the ones that are in that Q&A. Go ahead.
Okay, can you see the dashboard here on my screen? Yeah, okay. So as I mentioned earlier, it's something that you need to have login access to. So this is not publicly available, but anyone who requests will be granted. It is supported by the Nevada Hospital Association, which is federally supported for their burn disaster preparedness. I don't know if any of you have ever heard of Burning Man, where they go and light things on fire in the middle of the desert. I don't know what could go wrong with thousands of people in the middle of nowhere with the big burning structure. So that's where this came from. So you can see here by coalition, if you want to spy on all of the burn centers in the US, they are all geographically located here, and Canada is here. What I really like this for is less about the burn beds, but more as a registry of where are our burn resources in Canada. So you can see we've got the name here, the state or province, county, we just put the city, and then whether they do pediatric or adult and what their trauma level is. So oftentimes burn patients will be a mix of burns and trauma. So we're often looking for level 1 trauma. And then the contact information as well. If you click on the little house, will give you the main number and where they're at. You'll see here on the Calgary one, this is the one that I update. I include a sticky note here. So I just post our transfer referral call center. This in Alberta, it's called Rapid. So if someone is a care provider in rural Saskatchewan and they say, oh gosh, I have 5 burn patients, where do I go? I'm hoping eventually that this gets enough traction across Canada that they go, oh, actually, I know exactly where the closest burn center is. I know how to contact them. And it fields people through the proper channels. This is not my charge nurse or me accepting care of patients. I'm just directing people to the proper channels. And then the burn bed counts here for adult and pediatrics, and you can see when they're last updated. Our goals are to update every Tuesday. That's my long and short of the watchboard.
Excellent. If you want to stop sharing, then we can pull up all the panelists' faces here. First, before we get into all the questions, I want to say how appreciative I am of you raising our level of situational awareness. I think that this is something that isn't well known within our healthcare community, but as well as a number of other community partners and so on. And I'm sure we'll have folks that are attendees that are not directly working in a hospital that will find this sort of, update of information from across Canada very valuable. There were a number of things that I could pull at, but I do want to start with one question that was in the chat that I think was a really good place to start, which is the supplies. So, what process do we have in place to ensure we have adequate supplies, but also are there certain supplies that are more challenging to source? Should there be some sort of stockpile system with this? So I don't know who would like to answer that question, but fill us in on what supplies we should have and how challenging it might be to get those.
I will just make one comment, then I'll pass it to the panelists. But in that March 2023 home explosion, we exhausted the supply of one type of dressing called Acticoat that we use in burns. We exhausted the entire Canadian supply. I had the company rep, bring in the spare pieces she had at home, and we were shipping in from the UK. So it quickly exhausted within the first week of those 7 patients. And that was a challenge, and we had to start going to some different options. But maybe Mo wants to speak to that.
Sure. For us here in Vancouver, we actually took an inventory of everyone that has burn patients, them being the OR, us, emergency, and ICU. And then we worked with our partners at HEMBC, or Health Emergency Management BC, and kind of not really came up with a formula, but just kind of said, okay, how much more should we have? So we have a code orange shelf that's actually painted orange in one of the corners of our supply area, and it has everything from Acticoat to Flamazine to gauze to fluid resuscitation. We just had a patient who was admitted, and they're getting fluid resuscitated, and they're getting 600 mils an hour. So very rapidly, your fluid supply is also going to get drained. So we've actually, it's a hard science because you don't know if you're going to get 3 patients or you're going to get 30 patients. And the issue with a lot of the supplies for us anyway, and I'm sure for everyone, is they expire. So you don't want to over order where you're just wasting money. And we have an amazing stock person. Her name is Tina, and she every 2 weeks goes in and rotates everything in and out from the front line where they use the supplies to our emergency supply, so that our emergency supply always has the best before date as best we can. And then we're just managing it that way, but it's not an exact science, unfortunately. But we've just kind of said, okay, we can take up to 35 patients, and if they have 60% or more, this is a guesstimate. We do have a fulfillment center out in Langley where they can get couriered. It's like 2 hours away or something, back and forth, but it's not an exact science, but that is what we have done to try and mitigate that issue.
So I think everybody's shaking in their boots a little bit. Stephanie, I think I saw that you wanted to jump in on this too.
And I have to agree. It doesn't take a lot of burn patients, especially when they have an extensive, large TBSA, to utilize all those resources in 1 to 2 dressing changes, let alone between operations and then coming back for their dressing changes. So it's, once again, you don't want to overstock because of expirations, but at the same time, it can be an overwhelming amount of supplies required that vendors cannot keep up with the amounts. Whereas we've had to outsource previously from another site from Sunnybrook, where we had to go to Africa just to get the large dressings of Gelinet, to be able to get Cutacel, to be able to do dressings for patients. And that was not during a mass casualty. So we're currently going to start to review to see how we could optimize what we have for burn supplies, and then be able to look at how can we utilize and make sure they're not expiring, but that maybe other counterparts also will be able to have them in the systems in the community as well.
It's great. Thank you for contributing to that point. There's a couple of other questions, and one of the ones that got submitted first was actually talking about accreditation. And I feel like Dr. Malik had commented about accreditation. I'm assuming, based on what had been said, we're talking a little bit more about that all hazards approach, but is there anything that the panelists are aware of in the accreditation standards that mentions this specific type of mass casualty preparedness?
I think they are just putting all hazards together just to have something there. As I said, CKIDS, they have a good BMCI, as well as Sunnybrook, and I'm sure Hamilton as well, and also having Danielle onto the Alberta, they have a strong view there. So I think we need to advocate to be included slowly into accreditation. So every time when they review the standards, maybe we can say, if there is a burn program, that's what you should have. Do you have something there? But as I said, because it's it's so specialized, if you know that you are a burn specialized service, I think you may need to have that. And I think what we're lacking in Canada is that we do not have a definition or an acknowledgement. These are the burn centers. So we don't have that. It's like when you have in the States, it's a bit different. But here we are accredited. We were trying to be accredited with American Burn Association standards, but I think across Canada, there is no definition like you have in the United Kingdom, where you know that you have a burn facility, burn unit, and burn center, and then you know exactly what patients are going where. There was a study that Stephanie Mason, the burn director at Sunnybrook, has done a few years back, and she looked on all the burn injuries that happen in Ontario, and over 35% of the burn injuries were treated outside burn centers. So that's again care that is provided outside, and that is part of norm as where we're managed at the moment without a burn mass casualty incident. But when that happened, we need to have a bit much more rigor and a bit more guidelines and steps of what needs to be done.
Thank you for that, Claudia. Danielle, I have to say there was a question that was targeted specifically to you because you had mentioned the consortium helping to support during an MCI. The question was, would that include coordinating load balancing across centers since beds are limited? Is there a centralized plan for the redistribution of patients, or are you just calling around independently?
Yeah, for anyone who's familiar with the American Burn Association, burn disaster regions, that's their approach, where their coordinator is the one who is saying, okay, we've got 20 burns, 5 can go to this one, 10 go to this one. In Canada, because of the way our healthcare structures work, and we have provincial health authorities, and we don't have the same systems as the states. I see my role not as the coordinator to decide patient destination, but I am a touch point who I can direct people to the Watchboard. Hey, do you know that this is here? I can get you emergency access within less than an hour. Let's have a look. Let's see where our resources are, connecting the conversations through the correct routes of what we would do in our day-to-day when we have one burn patient. We're going to do the same processes when we have 5 burn patients so that we are following the correct pathways and we are including the correct people. So I see my role more as a communication and more of an advocacy role than a particular patient destination coordinator, if that makes sense.
No, I think that helps clarify, but also this is getting me thinking about staffing. Somebody did comment in the Q&A as far as the trauma support being internal or outsourced. How do we staff up for these? How do we, it's maybe a little bit different in some of the more urban centers, especially when we hear about Toronto. There might be the ability to have some maybe movement of resources or personnel. I'm not sure what that looks like, but it seems like there's kind of that general question maybe from the audience of how does it work staffing wise when we have one of these scenarios?
Yeah, staffing's everybody's problem, right? That's I'm sure Mo is nodding. He does a lot of managing. Staffing's the day-to-day problem. That's the pinch point, really. We can put patients in closets and hallways and call it a burn bed, but what the crux of it is the staffing. So that's where in our plan in Calgary, we have a structured escalation approach of staffing models. So can we pull non-burn trained staff who are working on our plastic surgery side, can we pull them over to help support? They have some of the skills, not the full training. Really optimizing our physiotherapists and occupational therapists. A lot of them have scope of practice in wound care. So can they help with the wound care while the nurse is doing the fluid resuscitation? So really looking at some of those collaborative care models. The real challenge is the prolonged staffing, right? Everybody wants to come in on the day of the explosion. It's in the news. Everyone wants to be the hero and rush in. That's great, but we still have to staff for tomorrow and next week and next month. And that prolonged drain now onto the outpatient resources. Maybe now we've diverted some patients to the outpatient clinic. They need the staffing as well. So it's definitely a challenge. I don't know, Mo, if you want to comment on staffing.
Yeah, it's definitely the challenge. Exactly as you said, Danielle, it's like not just the immediate, but it's the ongoing. I mean, for us, we have a fan out list and we have different models of care. We call it team-based nursing, kind of what Danielle would say is if it came worst comes to worst, you have a specialized person and then someone that might not be trained, but can do other aspects of care. We kind of plan for multiple worst case scenarios and hope we never have to implement them. But yeah, that's similar to what you said. We just fan out, we call based on who's closest and kind of go from there and meet the needs as best as we can.
Well, turn to maybe a slightly happier topic. I love talking about training and exercises, and I think everybody here mentioned about the importance of having some sort of training, but also describing how multifaceted, a BMCI response is. So I'm curious if anybody wants to talk about, when's the last time that you had some sort of exercise run on a burn mass casualty incident? Are there any tips or suggestions that you'd have for the attendees on the call and how to run some sort of scenario along those lines? Who wants to jump in first? Mo, you're still on the screen if you want to be put on the spot.
Sure, I'm happy to. For us, we've done a lot of simulations and education in burn training, but MCI we haven't. We are developing one with our partners in Emerge Trauma, and we have a sim center here where it's a dedicated team that runs simulations for us. So we're working with them to try and come up with an MCI-like event for burn-specific sim that we're hoping to do in the Emerge, in the Trauma Bay. We're not quite there yet, but we're working towards it is what we're planning to do.
Anybody else want to share? Danielle, I saw you unmute.
Yeah, in Calgary, we spent 2 years developing our burn plan. Now it's live, so we are exercising it next month on March 5th. And that will be our first dedicated, focused burn MCI exercise where we're involving Emerge, the burn team, the ICU, the OR, supply management, and allied health. So TBD, soon, happening soon.
Okay, we only have a few minutes left. I wanted to ask, I think, a very important piece. Maybe each of you might have something to say, but what's the key message to our community partners about this? So again, reflecting that some of the attendees might not be directly working in a hospital. We can have people in other segments of healthcare. We can have representatives from community. We can have students on this call. What's one of those takeaways that you would want for some of those attendees to leave with from this session? Claudia?
I would say that although it is rare, the burn mass casualties incidents, they can have a significant impact on the healthcare from resource perspective, but also mentally for the healthcare professionals that are involved there. Second, you need to be aware that there are burn centers across the Canada and where the specialized care it is. I think reaching out to those burn centers to see what education or what education materials they have for other hospitals, for other emergency departments, and those emergency departments in the community to see, right, if we have a bus just crashed outside of ED, what can we do? So how can you incorporate and raise awareness of burns within the trauma? Most of our burn centers are on level 1 trauma. So within the institution itself, yes, we can create more awareness and also have the standardized simulations, but also is that transport, the surge, the continuity, is that how we can improve that. And even if we have paramedics or emergency services or ambulance or orange on the call, is that how can we update that? So in Ontario, we have a transport team for pediatrics, and every time when they onboard new, I give them a teach of what happens if you have to transfer a burn. So that's for the last 3 years we have this practice. Thank you.
Thank you, Dr. Malik. Any other key takeaways that you'd like for our community partners?
Find your burn team, talk to them. We need help. We need your expertise. We need your emergency management, your pre-hospital expertise, and start the conversations.
Excellent. We are right at 1. So if there's no further comments from our panelists, I'm very grateful for each of you attending today. Again, like I said, kind of that overarching awareness that you've been able to increase for everybody that's attended the call, and appreciating that the session's recorded so other folks will be able to tune into this in the near future and hopefully glean some of those resources. Especially, thank you, Danielle. I know you posted a lot of QR codes on the screen. So really appreciate that. So thank you, everybody. Danielle, Mo, Claudia, Stephanie, thank you again so much for participating. I think the last note from the session goes to Professor Alias Gary to sign us off.
Thank you very much, Misha, and the speakers as well as panelists. It was really informative and interesting talk, and I'm sure all our participants took away a number of very good points. It also reminded me the very unfortunate Halifax explosion in back in 1917, which was still is greatest disaster with a lot of burn injuries, and the need for such awareness and also capacity building events like this, although very, very rare what once happen. Of course, we need capacity to deal with them. Thank you all for sharing your knowledge, experience, and thank you all the participants for joining us. Please, this is a monthly event every first Wednesday of the month. The next session will be on March 4th, same time, same place, same link. You will be receiving notification about that. We will have great speakers, and looking forward to see you again next month. Thank you for continued participation. From us, bye for now.